All right, welcome to the shock training portion of the program. We're going to cover shock and trauma and a little bit on hemorrhage. So we're going to define what shock is. We're also going to discuss different types of shock. We're going to cover the different stages of hemorrhage and then cover treatment and then go to the conclusion. So shock is inadequate tissue perfusion, either through blood or through oxygen. Something isn't being perfused right. The body's tissues aren't receiving enough blood flow to stimulate or keep them alive. So the problem with shock is there's either an oxygenated problem or a blood flow problem. So bleed my own blood. Usually the number one cause of shock is usually hypovolemic. So hypovolemic is any internal, external hemorrhages. We're looking at vomiting, our dehydration, and our especially burns. We also GI problems and GI bleeds. Then we have a pipe problem. This is going to be distributive shock. This is going to cause the vessels or arteries to dilate where there's not enough volume to keep the heart circulating. There's a problem with the circulation in the body. Sepsis is a prime example of that. Anaphylaxis is another example. Acidosis causes it as well, and neurogenic and spinal shock. So we also have an improper feeling problem. So this is going to be our obstructive. So our tension pneumohemo, they're compressing something on the heart that's not allowing it to fill or empty as properly as it should. And a problem with that is usually there's an interference. With cardiac tamponade, we got fluid penetrating from going up. Tension pneumothorax, the lung has shifted, causing it not to be able to fill and expand properly. So a couple symptoms of tension pneumothorax is JVD, hypotension, muffled heart sounds, unequal chest rise and fall. Those are the big indicators. Or when you palpate your trauma assessment, you're going to hear subcutaneous emphysema. That means there's air entering improperly through the heart or through the skin. We got our tamponade, usually from an injury, something that's causing, or a viral or bacterial infection causing it. Usually it's fluid around the heart. Same thing, you see your JVDs, veins in the neck. You're going to see your hypotension. You're going to have possibly tachypnea, tachycardic. The difference between this and a tension pneumothorax is the clear lung sounds. You could also see from the backup filling of the heart, peripheral edema in the legs. And then a pulmonary embolism. Usually it's going to be with a chest pain, something's blocking the flow and obstructing how the body's blood circulates. If you notice a theme, we have JVD, tachycardic, tachypneic, and then hypotension. Patients usually going to be pale diaphoretic. Those are going to be key things that we see during most of these. And then is it a pump problem? Pump problem is a failure from an MI, ischemia, left or right-hearted failure, diastolic failure, systolic failure, and CHF. You got heart disease, cardiomyopathy, and end-stage vascular disease. These are all going to prevent the heart from functioning right. If you notice a theme, you may see tachypneic, tachycardic, hypotension, pale, cool, diaphoretic skin. Other than neurogenic shock, those are the things you're going to see in almost every one of these that's going to have a severe medical issue. Then we have compensated shock. The body can lose up to 25% of its blood volume and compensate. You may be breathing normalish. Some people may be tachycardic depending on your size. Your blood pressure could be in normal range, could be slightly elevated. Respirations are going to be fairly normal. And then you may be thirsty, a little bit anxious. Losing blood is going to cause someone to have a little bit of anxiety, so that's where that comes in from. Decompensated shock, this is when mechanisms fail. The pipes are empty, the heart can't refill, and you've lost too much blood for organ perfusion. So we're looking at altered level of consciousness. You can see your hypotension. You touch them, they're going to be pale, cool, and diaphoretic to the touch. They're going to have possible clammy skin, and they're going to be, instead of tachycardia or tachypneic and tachycardia, they're going to be bradycardic and bradypnea. They're pretty much have lost the failure to compensate, and mechanisms are just starting to tank on them at this point. Also in the stage one of the shock process, like I said, is compensated shock. The body tries to maintain perfusion through homeostasis. You're going to see your tachycardia is going to improve, your tachypneic. They're trying to perfuse the body and push a blood circulation through the vital organs. Blood vessels then constrict due to the tachycardia to maintain your stable vitals. Your heart rate increases to provide the oxygenated blood to your vital organs. Shock, the stage 2 of the process, the system is starting to be unable to improve through perfusion. That means the body's hit a point where it's tipping. If we can't correct it, we're going to start seeing a decrease. Oxygen is starting to be deprived to the brain, causing anxiety, restlessness, and erratic behavior. You're going to see altered level of consciousness. You're going to watch the vital signs of the patient, the skin color, and the heart rate all change. Stage 3, you've been in this stage for a long time. We either have internal bleeding or we haven't corrected the problem. Long-term poor perfusion causes permanent organ and tissue damage and failure. So we're looking, the heart starts to fail, the kidneys no longer can perfuse and circulate the blood, and they start to shut down. Your BP, your respirations, and your heart all start to decrease. The body starts to present as cold, pale, and cool. And the narrowing blood pressure. Narrowing blood pressure is an indication of shock. So if we got 80 over, say, like a systolic and 90 over 80, that is not a perfusing blood pressure. It is too narrow. Okay, we're going to go over classes of hemorrhage. So hemorrhage is the volume of blood that we lose. In class 1, we lose up to 500 milliliters. That's going to be something about this size. That means the body's able to compensate. We're doing just fine. We can stop the bleeding. There's usually no change in patient's condition, no change in patient vital signs. Patient's able to compensate for that. Then we start getting up to class 2, which we're going to be in between 500 and 1,000 cc's. This is when symptoms set in. You're going to have your tachycardia. You're going to have your tachypneic. You're going to have a widening pulse pressure, and you may be a little bit pale and diaphoretic. You're definitely going to be anxious. During our class 3, this is where we lose about one of these up to this volume of blood. If you think about it, that is a lot of blood loss. We can lose that in a thigh or abdominal space or an external bleed that we can't control. So symptoms with that are going to be, so like I said, your tachypneic, your tachycardic, your hypotension, pale, cool, clam skin, altered level of consciousness. The patient may be going bradycardic because that's going to impair the filling process of the heart, since that's a decent volume of blood lost. Then the next one is, this is the one that's concerning. We've lost 2 of these. If you see the volume of blood, that is quite a bit that the body has released out. Symptoms are shallow breathing, ineffective heartbeat, possibly unconsciousness. Patient's going to be pale and cold. We're going to talk about a triad later of this person could be starting to head to be hypothermic. So remember, we've got to correct this. We've got to keep the patient warm. We can't replace what's needed is blood, but we can replace some fluid to compensate and keep the pipes open. So there's an act of the body to thrive, to drive. This is what keeps us alive, and that's the body's ability to maintain that. So the narrowing pulse pressure causes the decreased cardiac output. The veins constrict to try to help increase that output and keep the heart and vital organs alive. Tachycardia helps increase cardiac output. That's why it does it. Shunts the blood, vasoconstricts, and pumps the heart faster to make up for the loss. Tachypnea helps maximize oxygen that is lost through the blood cells back into the body. That's why someone starts breathing fast. If you know if they breathe slow and shallow, the body's no longer able to compensate for that, and they're definitely becoming unstable and they're circling the drain. Pale, cool, and diaphoretic is the same thing. The body's shunting blood away from the lower extremities to get it back into the core. You're going to feel cold hands. You're going to be pale, cool, diaphoretic. That is a sign that something is malfunctioning majorly, and the body needs those to perfuse the other organs that are keeping the body alive. So the goal of treatment is, remember, address all life threats. Stop the bleeding. Circulation, airway, breathing is the priority, especially during a trauma. So the goal is to restore a blood pressure, but we don't want to maintain a blood pressure that they would normally have, say 130 to 120. Our goal is to get them at least a systolic of 80. If we hit around 90, we can teeter-totter down. But sitting in the 80s, perfuse the organs, you can possibly feel radial pulse. You're going to give them what they need to sustain, keep the kidneys alive, the heart alive, liver, spleen, and everything like that. Patient's probably going to need an O2 as well, because we've just depleted their oxygen saturation that's circulating the blood. They're going to need that replacement. Shock treatment, like I said, treat all life threats. early recognition and early transport. We can help sustain them in the field as long as we keep our transport times at least 10 minutes or less, but we can't fix what's going on. They need an ER, they need a surgeon. The things we can immediately, they got a tension pneumothorax. Remember, if they're showing 2 or 3 signs, hypotension is a key in there. Unequal chest rise and fall, tracheal deviation, JVD, they definitely need to be decompressed. O2 needs, remember large bore IV access. Ideally, we want to get 218, 216 gauges. If that doesn't happen, remember you can do an IO if the extremity isn't injured. So we want to reassess vitals every 5 minutes to see if we got them trending up or trending down or staying the same. That's vital to know, especially when we get them to the ER. Keep the patient warm. This is one thing that we forget. Just like a newborn baby, that back of the ambulance needs to be hot, uncomfortable for us. It's going to be cool for them. I know we have heat blankets in there. We got hot packs to kind of help keep that patient warm. There's 3 things that's going to kill a patient, and we'll talk about that in a second here. The shock triad of death, this is part of it. Shock triad of death is hypothermia is one of the main killers of trauma. So just remember, it helps with poor perfusion. It prevents the body from being able to form clots, so it breaks them down and allows the bleeding process to continue. And also acidosis. Acidosis affects clotting factors as well that are going to need to be addressed, and it increases lactic acid buildup, which is going to affect the kidneys. It's going to cause severe muscle pains and aches as well. And then, I can't even pronounce this one, coagulopathy is my best guess. It's when blood loss, we've depleted so much blood volume from say, this much blood seeping out of the body that the fibrin and clotting factors no longer exist. If we can't stop the bleed, they're just going to continue to bleed out, and there's pretty much nothing going to prevent them from stopping. Okay, we're going over, these are my reference sources. So just remember, anytime we have a patient, just remember, we used to be taught it was airway, breathing, circulation. In trauma, it's circulation, airway, breathing. We got to stop the bleed and address all life threats, whether that be tourniqueting, needle decompressing, a load and go. The commonality of all these is, except neurogenic shock, is they're going to be tachycardic, tachypneic, they're going to be hypotensive. Their skin's going to be pale, cool, and diaphoretic to the touch. That means there's something severely going on. The extent to that would be our neurogenic shock, which is going to be elevated blood pressure, bradycardia, bradypnea, irregular respirations, and posturing, but the skin's going to be warm. That's going to be the difference between those two. It's the only form that's going to change. So that's all I've got for you on trauma and hemorrhage. So thank you guys and have a great day. Well, that's nerve-wracking as hell because I hate speaking in front of people. And when I give a lecture, it's usually like 5 minutes long. Like, I don't need backfill, I don't need fluff. Yeah. Well, if someone fact checks, have to say, yeah, that's false, but oh well.